welcome everyone to our October Dunlevie lecture series. A few center updates. The Dunlevie MFM Center's Fall Symposium is Advancing Maternal and Child Health Through Obstetrical Clinical Trials. It'll be on November 13th from 5:30 to 8:30. We'll have both national speakers as well as our local team here. It should be a really nice summary of some of the challenges in running clinical trials, both single institution and national clinical trials, and we hope for folks to join in. I'd like to extend some congratulations to the Dunlevie MFM Center faculty grant submissions for this month. Dr. Virginia Nguyen for her project Determinants of Endothelial Dysfunction in Preeclampsia, Dr. Catherine Bianco and Dr. Deirdre Lyle for Metabolics of Placenta Accreta Spectrum, MCHRI CE grant, and Dr. Matteo Mole exploring the black box of human embryo implantation, an MCHRI pilot grant. So congratulations to all of you for this wonderful accomplishment. Our next meeting is on November the 9th, and we will feature Professor Sarah England, Professor of OBGYN, Washington University School of Medicine in St. Louis, and she will be talking about chronodisruption effect on pregnancy outcome. Okay. So our presentation today is by Dr. Elliott Main. I'd like to say a few words about Dr. Main. Who is a nationally and internationally recognized figure in our field. Dr. Main founded and directed the California Maternal Quality Care Collaborative for the last 16 years and served as the chair of the the California Maternal Mortality Review Committee during those years. Nationally, Dr. Main is the Director for Quality Improvement Implementation for AIM, the national project funded through HRSA and based at ACOG, for supporting state perinatal quality collaboratives in their efforts to reduce maternal mortality and severe morbidity. Dr. Main is Clinical Professor of Obstetrics and Gynecology at Stanford University and a member of the Dunlevie Maternal Fetal Medicine Center Perinatal Epidemiology and Population Health domain. He has served or chaired national committees on maternal quality measurement for ACOG, the AMA, the Joint Commission, Leapfrog, and CMS. He has authored over 150 articles on maternal mortality, improving obstetric outcomes, and perinatal collaboratives. In 2013, Dr. Main received the ACOG Distinguished Service Award for his work in quality improvement. He is with us today to present on obstetric sepsis, time for care redesign. Elliott, welcome, and we look forward to your presentation.
Thank you, Yasser. And what I'm going to be talking about today is really the culmination of two lines of inquiry. One is building on what we have done for hemorrhage and hypertension in terms of quality improvement efforts, which has been taken up nationally and is centerpieces of AIM and perinatal quality collaboratives around the country. The second theme is building on a grant that we got from NICHD as a UG3 planning grant for maternal sepsis, which is the next leading cause of mortality and morbidity besides hypertension and hemorrhage. And we've been working on that for 2 years and now have succeeded in a 3-year extension for UH3 for actual implementation. So I'm going to go through what we've learned in the last 2 years and what we're planning to do and the excitement. So this is national data on maternal mortality. It's been released every 3 years until up to now. And you can see that the direct causes here on the left have all improved over time. Hemorrhage, hypertension, embolism have all had a serial reduction. Infection has not. It stayed box stable over this time period. And in fact, this is the latest time period from the CDC for national data. When you look at the different time periods of pregnancy, and in delivery, you could see different causes are in the top three. And during pregnancy, infection is the number 3 cause of death, but actually, as well as in the immediate postpartum period. But in the 7 to 42 days, it's the leading cause of maternal mortality. So sepsis is up there. And this is work that Susan Carmichael led, that I was part of, and Ron and others, which is looking at the role of severe maternal morbidity components, the indicator categories, in a longitudinal data set that allowed us to look at the antepartum periods, the birth admission period, which is the typical time that you look at severe maternal morbidity, and the postpartum period, again, in a longitudinal data set, which was really the first of its kind to do it. And what we see here is that sepsis is an important part of the delivery admission, but it's the dominant part, more than half of the severe maternal morbidity for antepartum admissions and for postpartum admissions. So this is really crystallizing the importance of sepsis. Summarized in this next slide as the second leading cause of maternal mortality, third leading cause of maternal morbidity in the antepartum and postpartum periods, and it has significant racial inequities. And if you look at this for severe maternal morbidity, it is twice as high in Black birthing persons, also high in American Indians and in Asian Pacific Islanders. One of our challenges is that there are many different causes of maternal sepsis that can lead to death. And they vary in the antepartum, intrapartum, and postpartum periods. So why are we doing poorly with maternal sepsis? We know how to treat sepsis, but it is relatively rare diagnosis clinically, but it's quite deadly when it happens. Sepsis is not first and foremost on patients or even physicians' minds, and that makes symptoms that are kind of indistinct often dismissible. And we're going to talk about that as we've done a lot of interviews with physicians and patients as part of this project. So that symptoms, they may be as simple as extreme tiredness, or which is something that is common in pregnancy and particularly common in the postpartum period, but it tends to be dismissed. Diagnostic criteria are not standardized. There's big debates in the U.S. about what the proper definition of sepsis is, and let alone maternal sepsis, and that leads to delays in treatment, and treatment that is often piecemeal. And then there's the special challenge of chorioamnionitis, which we're going to talk about in detail. So for the UG3 NICHD grant, which is titled Community Co-Led Redesign Maternal Sepsis Care, we started off with a sepsis community leadership board who co-designed and is co-leading this project. They have been particularly active as we've moved to identify patient-based barriers to care for sepsis and clinician-based barriers to implementation of potential maternal sepsis bundles. And we've done this over the last 2 years with qualitative approaches. At the same time, on the right-hand box, we wanted to address the diagnosis limitations that we have currently with identifying maternal sepsis. And so we wanted to establish test characteristics for a variety of screening criteria and for end organ injury during pregnancy, in which has different criteria and different physiological changes. So that's a quantitative approach. All these were then built to design strategies to implement an evidence-based sepsis bundle at scale. Our sepsis community leadership board included patients with lived experience, patient advocates, birth equity advocates, and community leaders engaged in reducing disparities, both from around California, some national, we tapped into national sepsis community groups such as Sepsis Alliance, Sepsis Aware, and this has all been led by Kendra Smith, who is a community engagement expert who we've been worked with on several projects in CMQCC. And she's leading and chairing these groups. We did this and integrated this with our research component, and we designed from the beginning an equitable combination structure and look toward reducing power differentials. We started off with patient interviews with 19 maternal sepsis survivors, the biggest group of survivors ever that's been interviewed, including one partner of a maternal sepsis non-survivor, sepsis advocacy focus groups, and two health equity advocacy groups. On the provider side, we interviewed 18 OBGYNs or MFMs, two nurse focus groups, two midwife focus groups, and 5 administrative MCH interviews. These were spread actually between California and the state of Michigan. This is a project being done in concert with my co-PI, which is Melissa Bauer, a national expert on maternal sepsis, who's an OB anesthesiologist currently at Duke, but has long ties to Michigan. And we're going to be doing these projects in those 2 states, Michigan and California. So some of the things that we've learned, the themes that we've gleaned from the patient interviews are presented here, just a couple of them. First of all, and a surprise to many, pain and unresolvable pain was the most common symptom. But this led to a lot of dismissal of patients as drug-seeking and did not get the appropriate examination or imaging studies. Patients often presented multiple times to healthcare environments and to providers, but were met with reassurance, i.e. saying, oh, you're just fine, not to worry about it, rather than further exploration of symptoms. They often were dismissed very quickly without follow-up questions, and interviews both with patients and then obstetricians realized that phone triaging for particularly postpartum patients is a weak link. It's not standardized. It's often managed with nurses without protocols. And it's basically serves as a place where folks get reassured. None of the patients that we interviewed knew what sepsis was before, in many cases, many days into sepsis, and they did not know what to look for. And they thought this was a big failing. If I'd known what signs to look for, I would have known it when I saw it. Or I think if they discharged me, if they had said to be on the lookout for these symptoms, if you have any of them, call and check in. If they'd taken 5 minutes to do that, I think I would have made a huge difference in my care. Many of these women that we interviewed had very major complications, including long-term hospital stays and ICUs, almost losing limbs, having major complications from the medications. This was a serious disorder. This is a big one. Patients did not feel that they were being listened to. I don't feel like they ever took my concerns seriously. They were brushing me off, trying to get rid of me. They wanted to send me home saying, take this anxiety medicine, you're going to feel better. You know, we've seen similar stories when we interview patients for the hemorrhage and hypertension protocols, and that led to the development that I speak about a lot when I talk about maternal mortality, is the 3 deadly Ds: denial, delay, and dismissal. Denial by physicians that this could be an issue, even if there are abnormal vital signs, like trying to find other reasons for a pulse being high or blood pressure being low, delay in treatment, and then, as we've seen here and elsewhere, dismissal of patient's symptoms. Patients wanted a way to advocate. They wanted know how to get the attention of the healthcare system. So there were a number of comments in the community leadership board is very strong on this as to what we can do to advocate for ourselves. One of the key things was to know what the warning signs are. To this extent, the ACOG Council of Patient Safety, which I've been part of, and which was then adopted by the CDC, developed this nice rubric for urgent maternal warning signs, which are valuable for all forms of severe maternal morbidity, whether it's preeclampsia, hemorrhage, sepsis, cardiovascular disease, or even depression. So this was a nice graphic that is actually now available in 14 languages. And this is one area that we are hoping to have hospitals adopt as a very clear-cut thing to do. In fact, we have, with our Michigan group, we've made this so this can be easily put on people's phones. When you think about how to make things accessible, everybody nowadays has a phone. You could put this as a tile on the phone, so not as an app where you need internet connection, but basically something like a PDF. We made simple directions here that you can go on this QR code or go to this a website, pick your language. Of interest here in California, there's mostly Asian languages are included, including Vietnamese, Hmong, as well as the usual broader number of languages. But you basically pick the language and select it and click on the button that says add to your home screen, and it's there as a tile. So it looks like an app, but it is available even if you're not on the internet. And this has been very well received in pilot projects in Michigan, and one that we're excited about. Because you give people a piece of paper and it gets lost, but you want something that they have with them. We've looked at magnets for refrigerators, etc. But this is one that people have with them, and their partners can have with them. So I'm going to turn now to diagnostic criteria and our work on the quantitative side. And this is part of the challenges that we have. Classically, using the sepsis 2 consensus approach, sepsis was defined as an infection and 2 or more systemic immune response symptoms criteria, i.e., these are typically vital sign abnormalities suggesting inflammation. This was superseded with the recognition that SIRS was quite limiting by the Sepsis 3 International Consensus Development in 2016, which was sepsis was really life-threatening organ dysfunction caused by a dysregulated host response infection, i.e. basically infection plus SIRS plus organ dysfunction. Now, in America, CMS has a national required measure, and it defines sepsis as the old definition of infection plus SIRS. And then they have a secondary level of severe sepsis, which is sepsis with end organ injury. And this is the SEP1 measure that every hospital has to report. So this is quite tricky. And particularly as we'll get into, the SIRS criteria basically overcalls patients in pregnancy by a huge margin, because and I'll show the criteria in a moment. WHO, following that, has taken the sepsis 3 definition for maternity in particular. So maternal sepsis for WHO worldwide is a life-threatening condition defined as organ dysfunction resulting from infection during pregnancy, childbirth, post-abortion, or postpartum period. It's been endorsed by FIGO and is generally followed worldwide. And they go on, WHO, to say it's been the criteria of systemic inflammatory response syndrome, or SIRS, are not appropriate for use in diagnosing maternal sepsis and should not be used. And I'll show you data to support that. 3 years ago, we developed an algorithm to help improve the diagnosis and treatment of maternal sepsis in a toolkit that came out in 2020, which was really 2 steps. One is a screen that did pregnancy adjustment of the SIRS, and then a evaluation or action step, which involved drawing additional labs to look for end organ injury before you gave all the treatments that you wanted for sepsis. But it's been recognized that you can be pretty sick without yet having end organ injury, and you don't want delays in starting antibiotics or even a fluid load, and you don't want to necessarily draw a large set of laboratory values on everyone who is severe infection screen positive. And so this is the area we're following up on, is what to do in this area, how to evaluate essentially a 2-step approach to sepsis. So we clearly needed more data, but sepsis is rare. We're looking at 1 to 2 per 1,000 births. More common is other forms of infection, or in fact, you can be quite sick with infections, pneumonia, pyelonephritis, and obviously chorioamnionitis. But getting the end organ injury is uncommon, 1 or 2 per 1,000 again. So we had to cast our net widely. So we looked at collecting vital signs, laboratory data, and diagnosis codes and procedure codes, essentially EHR data, from a large number of hospitals. For the delivery cohort, we got 59 hospitals all across the country to give us their EHR data. All these hospitals were on Epic, and all of them had a Clarity backend that we could program to easily extract the data from. So these included hospitals in New England, in the South, the Midwest, the Prairie region, as well as California and Washington. They involved 11 major teaching hospitals out of the 59, including places like Brigham and Women's, Duke, UCSF, Northwestern, as well as a even larger number of community hospitals and small hospitals. So this is a pretty nationally representative sample, not just from a network site of universities, but really representing the cross-section geographically and by type of hospital of the country. And include, as you see, city populations, some very, very small communities, as well as some urban areas. We looked at 4 cohorts from these hospitals. These hospitals over this 5-year period had almost 600,000 deliveries. And so we were able to identify almost 3,000 cases of maternal sepsis, which is far and away the largest group of maternal sepsis ever studied with this kind of data. We have 2 cohorts for delivery with and without chorioamnionitis. That'll become pretty clear in a moment. And then we had different cohorts for antepartum and postpartum. I'm going to concentrate on the delivery group, because we're going to drill that down in detail. For chorioamnionitis on the right-hand side, we were able to get almost 15,000 cases of chorioamnionitis and endometritis. This was about 90% chorio. The 2 are pretty related. These were all cases of chorio in this population, identified by ICD codes, which is a limitation. But if you're going to look at 59 hospitals, 600,000 births, you don't have the luxury of doing chart review. So we then divided that. I asked who had codes for sepsis, and there was 1,000 sepsis cases out of this 14,000. And end organ injury was about 23% or so, 238. So then we looked at the cohort all the deliveries without chorioamnionitis and looked for sepsis. So we found another 640 cases of sepsis, 228 with end organ injury, and we matched these 1 to 4. So each case of sepsis had 4 cases that were matched for gestational age because sepsis occurs much more commonly in preterm gestations than at term, except for chorio. So we wanted to be able to compare and contrast to similar gestational ages. So we looked at the typical screening criteria that have been used for sepsis, used for early warnings criteria, and then the 2 pregnancy-adjusted screens for sepsis. So on the left, you see the SIRS criteria that I mentioned at the outset, which is part of the definition historically for sepsis. Again, sepsis was still defined by CMS as infection plus systemic inflammatory response syndrome. And that included a white count over 12, a heart rate over 90, respiratory rate over 20, or temperature over 38, any 2 of those. Now, it's for anyone taking care of pregnant women, you will recognize immediately that an awful lot have heart rates over 90 in labor, or respiratory rate over 20, and the white counts are often modestly elevated in labor. So you get a really high screen positive rate, and we'll show that number in a moment. Then we looked at maternal early warning MUs, or signs, which are often used to identify people at risk for severe maternal morbidity of all kinds, hemorrhage, hypertension, et cetera. There's different places have come up with slightly different versions. MEWC is what's used in New York City in their quality collaborative as a maternal early warning criteria. They push the heart rate up to 120. They've included blood pressure, respiratory rate of 24, et cetera. And any one of those in their criteria would get you in. Whereas here in California, Larry Shields developed MUTE, maternal early warning triggers, which had a concept that's of interest, which had, if you have one really bad abnormal vital sign, like a pulse of 130, respiratory rate of 30, you're in. Or if you had 2 yellow flags, which included then a pulse of 110, temperature of 38, were also triggered positive. We developed 4 years ago a version that was based on MUTE because they had a pretty good data set. So there are a lot of similarities there. A white count over 15, a pulse of 110. But again, any 2 of these would qualify you. It was quite similar to the process done by the UK in their obstetric surveillance system. We've done a lot of collaboration, CNQCC, with the Confidential Inquiries of Great Britain, and now called UCOS, over the years. And it ended up independently coming to pretty similar issue, i.e. revising these 4 criteria to be more appropriate for pregnancy, with any 2 being abnormal. So how did this work? In this big cohort of first in screening for intrapartum sepsis, excluding those with choreo. And here we're looking for a balance between a screen positive rate, which is going to be a false positive rate in our population of without sepsis, and at the same time trying to get as many patients as possible to have a high sensitivity. So the balance between these is typically calculated as a C statistic. When you want to be at least 0.7, ideally over 0.8, and you're really good if you're in 0.9 or more in a C statistic. So CNQCC had the lowest screen positive rate, which is a good thing, and a pretty good sensitivity of 90%, 91%. If you scroll over to screening, how does it work for picking up those with end organ injury? It picks up 97%. SIRS, however, has a screen positive or a false positive rate of over 20%. And MUC, the one abnormal value, had almost 40% of normal patients would be screen positive. So these failed pretty quickly on that, though they obviously, if you have a very high screen positive rate, you're going to have a little bit better sensitivity way across. UCOS, again, with pregnancy adjusted criteria, is similar to the CMQCC, a little higher screen positive rate, but a good sensitivity. The mute is a relatively low screen positive rate, but it misses out on sensitivity because for sepsis, for infection, they require you to have a fever. And one of the interesting things that we've seen in the patient interviews, as well as in this data, is you could start off, and in maternal mortality reviews, that you don't necessarily start off with the fever with infection, that often a high pulse rate is much more important. So this was a positive finding. We were encouraged by this. And then we turn to chorioamnionitis, and that gives us a little bit different story. So this is all patients with choreo, and asking whether or not they had sepsis. The first cohort was really looking to see how well this worked in the face of changed vital signs in pregnancy. Now this is looking to see what about the changed vital signs you'll see in chorioamnionitis. Is basically, by definition, most everyone in choreo will have a fever of at least 38. And here you could see the problems that many of the screening tests have when applied to choreo. It's been published elsewhere, but the SIRS criteria is basically abnormal in almost 90% of cases with choreo. MUC is 92% positive in patients without sepsis with choreo. UCOS and CMQC are a little bit better, but 60% is a big rate of positives in patients without sepsis. So these C statistics are not very exciting. 0.67 is close to that 0.7, but it's not a very good number compared to the earlier one. These are all pretty sensitive in terms of not missing many cases with end organ injury, well into the 90%. But it makes us have to rethink how we're going to approach patients with chorioamnionitis. So what we've learned so far is for intrapartum screening for the general OB population, the pregnancy-adjusted screening tools have the best balance between sensitivity and false positive rates. But chorioamnionitis is a problem. It's a challenge, and that represents 2 to 5% of births. But it does have both a high rate of false positives, but it has a higher rate of sepsis and end organ injury than the general OB population. So we have to look at this in probably a two-step process. Not shown here, but the antepartum and postpartum screening, we were looking both at sensitivity and specificity, but also looking to see when in gestation you should use the pregnancy-adjusted values. And it ends up that the CMQCC criteria and the UCOS work quite well, work better than SIRS after 20 weeks of gestation and before 3 days of postpartum. And this is when you, not surprisingly, when you have the typical pregnancy-adjusted physiological adjustments for pregnancy. But early in pregnancy and further postpartum, the pregnancy adjustment doesn't contribute as much. And the ERs where these patients are often presenting is probably going to do better using their standard adult ER criteria, which is usually SIRS or a variation of that. So we have to be able to address high screen positive rates, particularly in choreo. So as we're moving to the next phase, we're looking at updating the CMQCC sepsis toolkit, again, with the goal of standardizing care whenever we can. We need to emphasize follow-up questions to patient concerns, We need to have better standard screening and have a standard diagnostic criteria for sepsis. And figure out how we're going to do the second step evaluation for end organ injuries and when to draw labs. And this is probably going to focus on a post-screen assessment of a bedside evaluation. So let's look at the next step first by going to WHO. And they've published just a year or two ago the basic simple rubric that we actually all are using, just not as simple here, which is if you have a confirmed suspected infection, you move to identify the source and the underlying cause of that infection, treat with appropriate antibiotics or do source control, i.e. drain an abscess, deliver a infected uterus, and continue monitoring. But then you have to figure out when to screen for organ dysfunction and how you do that screen for organ dysfunction. WHO is looking at a whole variety of low, middle, and high resource environments. And so they're looking at physiological parameters as well as laboratory tests. But this is where these are the patients that need a really more intensive care, big time fluid resuscitation, hemodynamic support, in many cases, respiratory support. So going back to the sepsis toolkit, this is the area that we need to focus on. We're going to be adding sections earlier about respectful care and listening to patients. But then we're going to be, for the clinical side, we're going to be concentrating on this next step after the initial severe infection screen, which seems to work in general, but not so well in choreo. But what do you do with those patients that are at higher risk before you go with full bore with sepsis treatment and laboratory evaluation? So we've been working on this with our clinical advisors and our patients for what should be part of the bedside evaluation. And this is an interesting group that includes actually the president of the Society of OB Hospitalists, who are now in an increasing number of US hospitals, and the chair of patient safety for the OB Hospital Society, as well as folks from OB and MFM from Michigan and in California, and nurses and midwives. And we wanted to have a screen process for drawing labs that was straightforward enough for nurses to use, as well as hospitalists, as well as ER physicians who might be the only ones in-house in a small or critical access hospital. So we have to be able to evaluate and rule out that bleeding is the cause of the abnormal vital signs, because that is more common to have external or internal bleeding. But then there's a number of systems have reported that a nurse or physician assessment that this patient is really sick, it makes a big difference. That she's toxic, she's really ill appearing, or if she has mental status changes, i.e. is confused or somnolent. Those are really, really, any of those are really high risk and need to be addressed quickly. You need to listen to the patient's concerns and then look at a fuller set of vital signs for red flags. So, and we're doing a evaluation of that currently as to what levels of higher temperature or higher pulse rate would give you a red flag. So if you have any of these signs, you would have a next step evaluation with laboratory data and physician and obstetrician engagement. We think this could be a simple checklist, which is how you move along without denial or delay. The symptoms are pretty common. This is an ACOG document. The last month was Sepsis Awareness Month. Around the country, there is a maternal sepsis awareness week in May that we're going to actually be jumping on as well. But these are ones that we know, but sometimes dismiss. High heart rate, oh, she's just in pain. People breathe faster in labor. Pain is part of labor, not uncommonly. But if you have these kind of symptoms and you have the abnormal vital signs, you have to take it much more seriously. So this is kind of an interesting concept. When I was looking for different models, I started thinking about what our neonatal colleagues do, which is a neonatal sepsis calculator for term mothers to rule out neonatal sepsis at term. And this has revolutionized that evaluation away from the CDC criteria that would have too many false positives. But basically, it's taking some clinical data, some vital signs, laboratory tests, and giving a risk level, but then it's evaluating the patient, a clinical exam, and then a follow-up, because we know even with a normal clinical exam, there are babies that will get sick at 6 or 12 or 24 hours later. Bill Bennett, who's been the longtime director of neonatology here, an ID specialist, and I had some long talks about this. And he showed me some data that the most important parts of the calculator is a standardized clinical evaluation and enhanced observation. And so we're essentially modeling what we're proposing for sepsis after this kind of an approach, where you have vital sign abnormalities, you do a standardized clinical evaluation, enhanced observation, and then you act. We know the UK has and others have had some output of clinical signs to look for, or excuse me, the treatments. So that's not the problem. The problem is in recognition. So we're undertaking a large-scale implementation project that's going to be both in Michigan and in California using the existing perinatal quality collaboratives. This is funded by NIH. We have an AIM sepsis bundle that and our revised toolkits that are now out. The AIM sepsis bundle is led by Dr. Bauer and Ron Gibbs from here at Stanford. I was on this task force too, so we've been able to coordinate it with this CMQCC toolkit and be able to say, yes, we have a well-regarded state collaborative, and then we have national support from ACOG and the other national organizations involved with AIM, which includes AWON, ACM, and others. And we have serious support from places like CMS, and as part of the Blue birthing friendly status that everyone in the country is supposed to adopt bundles for hemorrhage, hypertension, and sepsis. So I'm going to end with that and see if we have a couple of minutes for questions. So thank you very much.
Elliott, thank you so much for this comprehensive, thorough, thoughtful delineation of an incredibly complex and challenging area, especially how to translate what we know into something coherent for pregnancy care. And this was really illuminating and helpful. There is a question in the chat from Ron Gibbs.
Yes,
actually, it's a comment. It's a comment.
Yeah.
Well, Ron's been an integral part of this process. And
so, Ron, why don't you make a comment then?
Right. So I just wanted to say how beautifully Elliott has laid out the problem and delineated the work. And I also want to emphasize the contributions of the co-principal investigator, Melissa Bauer, as just a great partner in this. Clearly, gaps in care have been identified, both from the illuminating qualitative research as well as from the quantitative. And what's attractive to me is that I think that these gaps in care are amenable to system solutions. So, for example, the problem of the patient being blown off. Well, we could work on a way of giving a red flag if the patient is having her second encounter or so, whether that's a telephone call or a visit, and alarms when patients meet certain criteria. So I'm actually very hopeful that this work will result in improvement.
Thank you, Ron. One of the ideas, for example, with the ACOG symptoms that are for severe maternal morbidity that if you have one of those symptoms and you call in, you probably should be seen. That's a trigger to be seen rather than just handled on the phone. So that's a systems type change that would be make a big difference.
I see our OB anesthesia folks coming online here. Do they have a question?
Yes, hi, it's Clemens. I'm from OB anesthesia. I did have a question. We are planning on a study a clinical observational study where we would like to study the cardiopulmonary function using bedside ultrasound in women with suspected intraoperative infection. Given the high false positive rate that you have presented, what criteria would you use or would you suggest that we should use to enroll these patients?
Sure. So, one of our problems in obstetrics is the lack of a clear diagnostic criteria for chorioamnionitis. It's basically that label gets used for almost anybody who has a fever in labor. A couple of years ago, there was a conference, a consensus conference that had III, and that has not really been adopted well across the country. But I think there is the opportunity to identify some vital sign criteria that really move you up the spectrum. Because you don't want to wait until you have full-blown end organ injury. And so we're looking for that spot in between just fever and full end organ injury. And I think we're running what I call the red flag analysis rerunning on this data set right now, and we'll be able to answer that probably in a couple of weeks as to who looks, what kind of vital signs are more predictive in the setting of chorioamnionitis. And I think that's something that we're all looking for as clinicians. So hang on that. Sorry, I can't answer that today, but it's coming soon.
Okay, thank you.
Great. Any other questions for Elliott?
There's another comment from Dr. Susan Crow saying, thanks to all, we have seen such an increase in rapid antibiotic availability due to this work. Grateful for pharmacy collaboration.
Yeah, that was a key part of our initial toolkit that we did 3 years ago, was to engage actually the pharmacists here at Packard. And it's, the antibiotics are not super special. This is, you start with AMP and Gent for chorioamnionitis, but it's sort of interesting. Gent, can take a long time to get to the pharmacy if you don't have standardized dosing. And that's not acceptable. We really want to get the antibiotics in with under an hour.
I have a question from Dr. LaFollette.
Yeah, hi, Elliott. Nice to see you and great presentation. Having had one of these patients that really did present as a mental status change in the last year, do you have a little bit of a timeline for us that are doing obstetrics in terms of when we should start to suspect something different compared to the normal? Because elevated heart rate is something we take very seriously when we're making the definition of chorioamnionitis, but down the line, we don't usually see it. And I just was wondering if there's any ways on a timeline for us to be sure we don't miss it.
So that's what we're developing. And again, we're not quite there. The data I showed you are in press now in the Green Journal, both the antepartum, postpartum, and the intrapartum. We're doing the final revisions on that, but that should be coming out hopefully by the end of the year. But it is going to be a combination of clinical signs as well as the abnormal vital signs that are going to drive it. But you have to have the suspicion, because we don't tend to think of it until the patient's really sick. But if you have any kind of confusion, that means you're not perfusing well, and it's either hemorrhage or sepsis essentially, or if you have hypertension and you have to think about preeclampsia. We're looking for the vital sign criteria that's going to be work for you earlier than those kinds of end organ injuries. So stay tuned on that too.
Thank you. Well, I think we have reached the end of this lecture, and thank you all. We had a wonderful turnout today for such a great presentation. Thank you, Elliott, and looking forward to working on this and seeing how things develop. And congratulations on your grants.
Well, this is the work of many, as always, and thank you for my collaborators. And Melissa has been a fabulous partner. I just wish she wasn't so far away.
Take good care. Bye-bye.